This program is brought to you by Emory University.
Well, good morning, everybody. Happy Friday. Welcome to another Friday Fellows Conference. Our speaker, as you can see this morning, is Dr. Wang. Bo is a second-year fellow in our clinical track. Bo is an Atlanta native, did his residency at UAB, and is, as you can see, also going to talk to us about coronary dissection. So, Bo, take it away.
Thank you, Dr. Williams. This morning, we're going to talk about SCAD for this particular case, titled it Surprising Case of Atypical Dissection. So for our outline, we're going to start with the case presentation, pathogenesis and epidemiology of spontaneous coronary artery dissection, diagnosis and imaging evaluation of SCAD, discuss indications for interventional versus conservative treatment, pregnancy-associated SCAD, long-term management, and future direction. So for this case presentation, we start with a 56-year-old male with a history of hypertension, diabetes, hyperlipidemia, and OSA, presented to the ED with 3 hours of active, sharp, left-sided chest pain. He was lifting weights in the gym when he started having this chest pain. In a baseline, he's a regular gym member, goes almost daily, and lifts weights regularly without any symptoms. Additional medical history consists of some alcohol use, 2 to 3 drinks every weekend, a long history of tobacco use, but 3 to 5 cigarettes a day on average, and no illicit drugs. He has no past surgical history, has family history of hypertension in the mom, and no medication. So when he came through the ED, he was 8 febrile, heart rate is 104, blood pressure 165 over 125. He's sat in one room air. His BMI is 24. He's in some mild distress from the chest pain. Then cardiac exam is notable for tachycardia. He does not appear hypervolemic or have any other significant findings. With the admission labs, he has a creatinine 1.12, hemoglobin 16.2, white count 12.6, and this is DVA, so it's point of care troponin 0.58. This is his initial EKG in the ED, shows significant anterior STEMI with elevation of V1 to V3 and ST segment depression in the lateral leads. Co-STEMI was activated and was taken emergently to the cath lab. So we suspected, since we suspected the LAD or left coronary disease, we went to that first. So coronary angiogram, the left coronary, we were using a guide catheter, shows a mildly narrow left main ostium. The left circumflex shows what we saw at the time as a chronic SCAD in OM1 with TIMI 3 flow distally. This also gives left to right collaterals as well. The LAD shows a focal 30% lesion, also with TIMI 3 flow. A second shot here shows the catheter pointing up in the left main and with some mild luminal narrowing. Again, we see the chronic SCAD of the OM1 with TIMI 3 flow distally and focal narrowing of the LAD. Overall, based on our initial impression, there's no clear-cut culprit lesion in the left coronary artery, so we turn our attention to the right. The coronary angiogram, the right, shows thrombus in the prox RCA with 100% occlusion that goes into the sinoatrial branch of the RCA. The distal RCA fills from left to right collaterals, and these angiographic findings are incongruent with the EKG findings, but given the suspected acute thrombotic lesion, the decision was made to intervene on the RCA. As we were exchanging wires and proceeding with the case, we were aspirating the radial sheath, and there was resistance in the syringe of aspiration and flushing. And as we were continuing to aspirate it, we saw acute thrombus coming through to the sheath. And the next slide, we actually managed to take a picture of it. And this shows the thrombus that was aspirated through the radial sheath, and it looked to us to be bright red, concerning for fresh thrombus. Re-engagement of the RCA and subsequent coronary angiogram after the incidental thrombus aspiration shows improved filling in the sinoatrial branch of the RCA. And at this point, the decision was made to go ahead and stent. And so after the RCA was stented with 2 stents, the patient had immediate relief of its angina. And as we were about to remove the catheter and close, the patient has sudden reoccurrence of his chest pain that was identical in character to his initial presentation. And the decision was made to reevaluate the left coronary. So upon reevaluation of the left coronary with a diagnostic catheter, shows acute dissection of the mid-LAD or distal flow. At this point, we also used IVUS as well to confirm the SCAD. And given the acute chest pain likely due to active ischemia, the poor distal flow, the decision was made to stent the LAD. The LAD after stenting shows timid reflow distally, and the patient had overall resolution of his chest pain. Post-procedural EKG shows reperfusion changes and resolution of the anterior ST elevation. In conclusion, for this patient, we thought for quite a while as to what actually happened, and we suspected the patient has SCAD called in 3 different time points. The OM1 shows evidence of chronic SCAD with timid reflow distally. The initial suspected focal atherosclerotic lesion, seeing the LAD, was perhaps a type 3 SCAD, and during the contrast injection of the left coronary, there was progression of a dissection flap of the LAD to progress throughout the case, ultimately turning into a type 1 SCAD. And for the RCA, there's the possibility of a recent SCAD that occurred 1 to 2 days prior to presentation. However, there's no definitive evidence. Clinical course-wise, the patient was placed in aspirin ticagrelor for 1 year with aggressive blood pressure control. So from here, we move on to a discussion about SCAD. It's defined as a spontaneous, non-iatrogenic, non-traumatic separation of the coronary wall that's not associated with atherosclerosis, leading to formation of intramural hematoma. SCAD is most prevalent in young to middle-aged women who have few traditional cardiovascular risk factors. This particular patient population accounts for up to 95% of all SCAD cases. And recent retrospective studies have shown SCAD to be the underlying cause of MI in 22 to 43% of women less than 50 years old. And this table here shows that SCAD accounts for up to 4% of patients presenting with ACS. In terms of pathogenesis, there are 2 predominant theories regarding how SCAD occurs. So the first theory proposes that the primary pathological event is the development of an intimal tear, which allows blood from the true lumen to enter and generate a false lumen. The second theory proposes that the primary event is actually spontaneous hemorrhage arising from the vasovasorum within the vessel wall. And this image on the right demonstrates cross-section view of the coronary artery. Image A denotes a normal coronary. Image B shows a coronary artery with intramural hematoma. And image C shows a coronary artery with an intimal tear. So this is a table of results from optical coherence tomography, otherwise known as OCT, series from patients with SCAD, which noted that an intimal rupture site could not always be identified by this type of imaging. And this finding supports the second pathophysiological theory in at least a proportion of cases. So under rupture site identification, left side's OCT, right side also used IVUS as well. So you can see there's 2 particular cases where even with OCT and IVUS, they were not able to clearly delineate an intimal tear. So image A, this is a histological image of SCAD. And image B shows a pathological sample of SCAD. So both show compression of the true lumen, as you can see as depicted by TL, by the hematoma within the false lumen as depicted by FL. Of note, in the literature, there are histopathology reports of periadventitial mixed inflammatory infiltrate with the predominance of eosinophils. However, there is controversy as to the significance of eosinophil infiltrate and as to whether it is pathognomonic for SCAD or suggests a non-specific response to vascular injury. So most notably, the absence of eosinophils in the intima and media in SCAD differentiates this condition from other vascular conditions, such as polyarthritis nodosa or eosinophil granulomatosis with polyangiitis, and also the absence of granulomatous inflammation or vasculitis in other tissues or organs throughout systemic inflammatory disease. So in terms of how this actually occurs, spontaneous coronary artery dissection often occurs in the setting of one or more overlapping conditions. In this particular diagram here, the blue circles show the patient's substrate, whether they have migraines, hypertension, or pregnant, or some other condition. And this is often precipitated by a trigger. So triggers can be intense exercise, emotional stress, Valsalva medications, or sex hormones. In our particular case, the patient had underlying hypertension, and it is suspected that SCAD was precipitated by Valsalva during intense exercise in the setting of hypertension. As to exactly why this happens, it is hypothesized that the catecholamine surge during these events lead to coronary artery shear stress that at least in part contribute to the pathophysiology of SCAD. Genetics-wise, so there has been a few familial cases of SCAD among first-degree, second-degree family members. The majority of cases are sporadic. And in the literature, SCAD is sometimes subdivided into familiar versus sporadic variants. And among SCAD patients who are referred to genetic testing, 5 to 8% have disease-causing mutation or arthropathies or connective tissue disease. And these consist of vascular Ehlers-Danlos syndrome, Marfan syndrome, and Lewis-D syndrome. And in particular, in the recent years, there's been more genetic testing and evaluation of these patients. And this particular gene here, PHA-CPR1, EDN1, this is a genetic locus known to be associated with migraines, headache, cervical artery dissection, and fibromuscular dysplasia, otherwise known as FMD. It has been shown at least to have an association with increased risk of SCAD. There's also additional genes associated, such as LRP1, LINC-CO00310, FDN1, and Adams SL4. These are all genes that are expressed in the arteries and are associated with other arterial disorders. So this is a table on the prevalence of conditions associated with SCAD seen in previous cohort studies. There is a strong association with fibromuscular dysplasia along with pregnancy, multiparity, and the use of exogenous hormones, which will be discussed later in this presentation. Most notably, taken from this chart, there's a greater than 50% association with precipitating factors, such as physical stress, which has been predominant in men, and emotional stress, which is predominant in women. There's also other associations, such as labor delivery, recreational drug use, and exogenous hormones. However, there's not good cohort data for the prevalence of these conditions in SCAD patients. In terms of SCAD and FMD, so like we said previously, SCAD has a strong association somewhere within 25 to 86% with fibromuscular dysplasia. And fibromuscular dysplasia itself is a non-atherosclerotic, non-inflammatory vascular disease that can affect nearly any arterial bed. It usually manifests as arteriosclerosis, aneurysm, tortuosity, or dissection. Most commonly, this is what we learn classically as multifocal FMD. It's defined angiographically. It's areas of alternating stenosis and dilation. And this is what we always remember as a string of beads pattern on imaging. So here in image A, this is a renal angiogram that shows string of B's appearance of multifocal FMD, which is pretty classic. In image B and C are CT angiograms of the same patient, showing the string of B's appearance as well. There is pregnancy-associated SCAD, given the high incidence of this condition in women, particularly young women. And the cause of pregnancy-associated SCAD is not fully understood, but current hypothesis, there's many, but one suggests that estrogen and progesterone receptors that are present in the coronary arteries themselves may weaken the vessel wall, which accumulates in arterial wall rupture and intramural hemorrhage. Additionally, accumulation of such changes over several pregnancies may explain the reported heightened risk of SCAD in multiparous women. And very interestingly, this is the most common cause of MI among patients who are pregnant or postpartum. This overall accounts for a prevalence of about 1.8 SCAD events per 100,000 pregnancies during pregnancy or in the 6-week postpartum period. And this most commonly occurs during the 3rd trimester or early postpartum period. In terms of clinical presentation, presenting symptoms for SCAD are consistent with atherosclerotic ACS, with chest pain being the most prevalent. However, the most notable difference is in the patient's phenotype. So these are patients with few risk factors for atherosclerotic disease. And the initial presentation of patients with SCAD is most commonly in the setting of ACS. STEMI accounts for roughly 26 to 87% of patients, while STEMI type 1 accounts for about 13 to 69% of patients. In terms of how to diagnose SCAD, coronary angiography is the first-line diagnostic method for SCAD, especially in the setting of acute ischemia. There are additional intracoronary imaging methods such as intravascular ultrasound, IVUS, or optical coherence tomography, OCT, that can aid in a diagnosis of SCAD are not widely available. In terms of the angiographic classification of SCAD, this is the Yip-Saul classification, and this is the most commonly accepted classification scheme for SCAD. So in type 1, contrast penetrates into the false lumen, and this gives you a dual lumen appearance, sometimes localized extraluminal dye hang-up, as it's called, following contrast clearance. This is pathophysiologically distinct from type 2 or type 3. And type 1 SCAD accounts for fewer than 1/3 of angiographic presentations and are likely to develop later in the disease course, probably as a result of decompression of the false lumen hematoma into a true lumen. And overall, type 1 SCAD is associated with a lower risk of clinical progression if managed conservatively in PCI. Of these three, type 2 SCAD is the most common appearance, and this is characterized by a long smooth stenosis and accounts for roughly about 68% of all SCAD cases. Type 3 SCAD, this is described as a lesion that mimics the appearance of focal atherosclerotic disease, and this can't be definitively determined as SCAD on angiographic images without the aid of intracoronary imaging, such as OCT or IVUS. And this is the least prevalent form of SCAD, roughly accounting for 3 to 4% of cases. So going back to our previous case, one hypothesis that happened to our patient was that he probably had a type 3 in the mid-LAD that developed after contrast injection throughout the case, turning into a type 1. Here, these images show coronary angiograms of the 3 types of SCAD. So image 1 shows multiple radiolucent lumens, type 1 SCAD. Here you can see the dye hang-up that's classic for this particular angiographic finding. Image B here shows diffuse stenosis consistent with type 2 SCAD, this long focal, this long narrowing with smooth borders. And image C and D shows the focal stenosis at type 3 SCAD, also with coronary angiography and OCT. So in terms of intracoronary imaging can be used to aid in diagnosis of SCAD if the findings are subtle or non-diagnostic in a regular coronary angiogram. IVUS itself offers deeper penetration of the vessel wall and can be useful in evaluating the depth of the intramural hematoma, but has lower spatial resolution than OCT, which makes it challenging to distinguish SCAD from lipid-rich stroma, which is another key differential when you're looking at these cases. OCT offers better spatial resolution than IVUS, hence the preferred intracoronary imaging method, but it has worse vessel penetration. So that's the trade-off, and also requires blood clearance or high pressure injection imaging, which is not something you typically want to do in patients with fragile coronaries. And here in the left image, top left, is OCT showing intimal dissection with the solid arrow and intramural hematoma with the asterisk. And image B is IVUS. It shows intramural hematoma with the dotted arrow, compressing the true lumen, which you see with the asterisk. The risk of any intracoronary imaging includes extending the coronary dissection with wire or imaging catheter, guide catheter iatrogenic dissection, and also catheter-induced occlusion of the true lumen. And with OCT, again, the hydraulic extension, contrast injection for optical coherence tomography. So these options should only be pursued when the coronary angiographic diagnosis is uncertain, such as in type 3 SCAD or unclear lesions, or only when the vessel diameter is large enough for intracoronary imaging. There are other modalities that can use also to evaluate SCAD. So one is, of course, cardiac computed tomography angiography. This is an emerging modality for the initial and interventional evaluation of SCAD. However, limitations include lack of diagnostic criteria for SCAD on CCTA, low spatial resolution for small vessels, a motion artifact, and unknown sensitivity and specificity. Of course, CCTA is not used in the initial setting, of course, in patients presenting with ACS-like symptoms with evidence of ischemia, but it can be useful in reevaluation of interval evaluation of SCAD in a patient who has been hospitalized if there's concern for the risk of recurrence. It bypasses a lot of the interventional risks of SCAD when it comes to catheters and wiring and forcible contrast injection. And typically, this is used for type 2 SCAD, in which there's diagnostic uncertainty. As to when to intervene in SCAD with stenting, the outcomes are less predictable with higher rates of complications and suboptimal outcomes as compared to atherosclerotic acute MI. This makes sense because this is a different pathological mechanism. So it's not atherosclerosis, but fragility of the true and false lumen in these patients. And complications include iatrogenic dissection, hematoma propagation, and stent malpositioning. And for PCI and SCAD, they currently accept the guideline to focus on restoring T3 flow and not on restoring normal coronary architecture. The take-home message is overall, PCI of SCAD lesions have elevated failure rates, with some lesions requiring subsequent CABG. And here we'll go through some complications of PCI and SCAD. So here, this is iatrogenic dissection. Image A shows coronary angiography of SCAD in the mid-LAD. That's normal distal flow. And then in figure B, the wire is advanced. There's loss of distal flow. And in image C, when they deploy the balloon to the false lumen, you see propagation, the dissection further leading to loss of distal blood flow. This image here depicts a multi-vessel SCAD in image A. In image B, it shows progression of the hematoma into the left main and loss of blood flow to the LAD after attempt to wiring of the coronary. And here, this is stent malposition. So image A depicts SCAD of the LAD, and image B shows proximal displacement of the hematoma as post stent deployment. And image C is IVUS confirming the underdeployed stent. What sometimes also happens is if the stent is deployed adequately in the initial case, as the hematoma resorbs into the vessel wall, it creates a space for the stent to end up being under deployer malposition because of the absorption of the hematoma into the vessel wall. So also something to watch out for in these cases. Just a note on coronary artery bypass grafting in these patients. This is only reserved for cases of stent failure, high-risk PCI, or high-risk anatomy. For instance, patients with left main dissection, active ischemia, or maybe two-vessel disease. However, these dissecting coronary arteries are already fragile and have difficulty holding suture, and that can be very, very difficult to bypass. And in particular, a subset of these patients also have underlying hereditary connective tissue disorders, which makes their coronaries prone to these difficulties and are already more fragile at baseline. And in terms of evidence for arterial versus venous grafting, that doesn't actually exist currently in the literature. So bottom line is these CABG is reserved for only last resort. This here is a table from a 2014 study by Tweet et al. They compare revascularization versus conservative therapy for SCAD. And in this study, patients treated with initial revascularization more frequently presented with ST segment elevation, cardiac infarction, compared to those managed conservatively, and had higher rates of vessel occlusion, larger vessel diameters, and higher mean lesion stenosis. So this makes sense. The patients who were revascularized had poor flow distally and had signs of acute ischemia. Here, the small percentage of occluded vessels selected for conservative management tended to be distal, small caliber vessels with good distal flow and non-amenable to PCI or bypass. As it makes sense, patients treated with revascularization had elevated risk of requiring emergent CABG, 13% versus about 2%, and primarily because of PCI failure in these patients. And there were no differences in 5-year outcomes in regards to death, recurrent SCAD, heart failure, target vessel revascularization, or follow-up left ventricular ejection fraction. So overall, what does that mean when we have a patient who presents with SCAD? How should we manage them? I think the take-home point is the goal is to restore or preserve myocardial perfusion or cardiac function. So in here, for management of SCAD, if they're clinically stable with no high-risk anatomy, conservative therapy is recommended. And also it's recommended to monitor them inpatient for 3 to 5 days. The reason for this is contemporary literature state that most cases of recurrent SCAD occur within 4 days of the initial event. And therefore, most experts advocate for a longer hospitalization observation period of up to 5 days. In patients who are clinically stable with left main or severe proximal 2-vessel dissection, the recommendation is to consider a CABG and to state that conservative treatment may be reasonable. I think this is where the controversy lies, or the lack of evidence really doesn't sway one way or the other. That there should be more data in the future, but for now, this leaves option up to the clinician in patients who are clinically stable but have anatomical high-risk vessels. Of course, in patients with active or ongoing ischemia or hemodynamic instability, it makes sense that PCI is considered first versus urgent CABG based on, of course, technical consideration, local expertise. In our particular patient, when the LED went down and there was poor of flow and the patient had active chest pain, we suspected that was active ischemia, and that's why we went and pursued PCI. In terms of post-procedural management, these patients oftentimes have post-procedural chest pain, and it's very challenging to differentiate ischemic versus non-ischemic etiologies of early post-SCAD chest pain. And the incidence of early reinfarct is anywhere from 6% up to even 17.5% in the literature. And of course, understandably, given the risk of iatrogenic dissection with coronary angiogram, the focus should be on avoiding invasive angiography and relieving symptoms of OMT, such as blood pressure control, antianginals, and pain control in the majority of patients, unless there is high clinical suspicion for recurrent SCAD. And if these patients come in and have heart failure or they were stented, these patients should be treated accordingly to standard therapy. Here, this table shows that in the majority of cases, conservatively treated SCAD lesions heal on their own, and that conservative therapy should be the primary choice of treatment unless there is active ischemia. So the spontaneous healing rates of all the studies, there are not a lot of patients, and the time frame is anywhere from 154 days all the way up to 40 months, and these spontaneous healing rates vary from about 72.9%, or even 52.9% up to 100. In terms of medical therapy, the goal of short and long-term medical therapy is to relieve symptoms, improve outcomes, and prevent SCAD recurrence. Beta blockers should be considered in patients with concurrent LV dysfunction, arrhythmias, or hypertension. There was a recent 327 patient case series out of Vancouver. The median follow-up of 3.1 years, it showed a hazard ratio of 0.36 for recurrent SCAD in patients on beta blockers. So at least right now, there's some signal that beta blockers can potentially decrease recurrent SCAD and should be considered in SCAD patients. There is, in terms of statin therapy and DAP, they are not recommended. There's no association found between these medications and recurrent SCAD. And antianginals are recommended for patients with post-SCAD chest pain who are not candidates for revascularization or have evidence of coronary vasospasm or microvascular disease. So in terms of management of pregnancy-associated SCAD, like we said previously, the majority of cases occur in the first 4 weeks after delivery. And it is recommended that you have a multidisciplinary approach with obstetrics. And in the acute setting, the management is similar to non-pregnancy associated SCAD, including timely coronary angiography, the patients having signs of acute ischemia. Like it was shown in the previous slide, again, there's no data with clopidogrel in non-PCI cases. And if the patient needs to be on a beta blocker, as with all pregnant patients, labetalol is the preferred agent. And since a lot of these patients who present with SCAD are young and female, there needs to be some consideration for pregnancy and contraception after SCAD. There has been a singular case series on 8 patients with subsequent pregnancy after previous SCAD. The median follow-up about 36 months that showed one case of recurrent SCAD after a subsequent pregnancy. Current consensus is to cancel these post-SCAD patients on the risk of recurrent SCAD with subsequent pregnancies, although the evidence is overall sparse. And a lot of these recommendations are expert opinion. So most experts advocate for vaginal delivery with minimal maternal effort and Valsalva effort. There's no direct evidence linking hormonal contraception with recurrent SCAD, but expert consensus is to avoid if possible. And recommended contraception options are vasectomy for the male partner, tubal ligation, or intrauterine device with local hormones, not systemic hormones. And given the association of SCAD with conditions such as FMD, the current guidelines do recommend whole body arterial imaging with CCTA or MRA. And the goal is to identify clinically important vascular complications that warrant treatment or follow-up. Of course, in these patients, common findings include FMD and intracranial aneurysms. However, there's no data right now on whether detection of extracoronary vascular abnormalities decrease risk for recurrent SCAD. This is a table on the prevalence of extracoronary vascular abnormalities, otherwise known as EVA, and FMD among SCAD patients in cohorts greater than 100 patients. On the bottom here, the largest cohort by Salt et al. Reported multifocal FMD in greater than 50% of overall patients, and head and neck aneurysm and pseudoaneurysm in 7 to 11%. Overall, the bottom line is that all patients with SCAD should be screened for FMD and extracoronary arteriopathy. To touch on recurrent spontaneous coronary artery dissection, the occurrence rate ranges anywhere in the literature from 5 to 30%. And like we said, it usually occurs within 4 to 5 days of the initial presentation. And this is why we recommend a longer hospitalization observation period in the patients who present with ACS. What's important is to differentiate a new dissection from extension of a previous dissection or intramural hemorrhage. As you can imagine, extension of the old dissections may also be accompanied by symptoms, EKG, and biomarker changes as well. In terms of what factors are associated with recurrence, due to lack of data, these have been poorly characterized. Some risk factors include severe coronary tortuosity, associated symptoms such as FMD, migraine headaches, and hypertension. In terms of physical activity after SCAD, given that the onset of SCAD symptoms correlated with physical exertion in up to a third of patients, it is very understandable that patients are often hesitant to resume physical activity after SCAD. However, contemporary evidence demonstrates overall net benefit to moderate intensity exercise. So there was a survey about 254 SCAD patients who reported net emotional and physical benefits to cardiac rehab. So just moderate intensity exercise. However, current expert opinion recommendations recommend that patients should avoid endurance training, prolonged Valsalva, such as lifting heavy weights, and also yoga with extreme head and neck positions. I think this is more due to concern for associated vasculitis or other connective tissue diseases, and to avoid exercise that exceeds max particular heart rate greater than 85%. In terms of future direction, to determine optical diagnostic techniques to consistently accurately diagnose SCAD, I think it's a big one, particularly in the realm of non-interventional imaging, such as CCTA or MRI. Right now, there's not clear guidelines as to when to revascularize a vessel and what are the optimal techniques given the risk of iatrogenic dissection, hematoma propagation, and also issues with stent malpositioning when the hematoma reabsorbs. Also, identification of factors to increase risk of recurrent SCAD and to understand the genetic variations associated with SCAD. Just for a plug, there is the iSCAD registry. Emory participates in the iSCAD registry, which is international and whose goal is to gather data into advanced SCAD research and to improve patient outcomes. Nationally, currently as of September 1st, there are currently enrolled 1,377 patients across 24 sites. In talking with Dr. Wells, Emory has enrolled about 100 patients to the registry. It's about the 6th highest enrolling site. There has been preliminary data that has come out from the SCAD registry in the form of abstracts with manuscript strips pending the next 1 or 2 years. And these abstracts have been presented at ACC and AHA. The first registry for SCAD was the Mayo Registry, which is exclusive to them, and also the Canadian Advanced SCAD Registry as well. So for this particular patient, the CTA revealed bilateral pulmonary embolism and lower extremity Dopplers showed right lower extremity DVT. Post-SCAD echo showed EF about 30-35%. He had a severely reduced right ventricular systolic function and a very small PFO. And as we did whole body imaging, the CTA head and neck showed evidence of mild calcified plaque bilaterally, but without evidence of intracranial abnormalities. And genetic testing for connective tissue disease was negative. And in terms of why this case was atypical, this is a male. His age was also atypical. He had no family history. He had no codominant arteropathy or vasculitis. And he had what we suspected to be an acute intraoperative coronary dissection. Given the finding of the DVT and the PE, the patient was placed on triple therapy for a few weeks and then transitioned to dual therapy. He was discharged. The CTA of the lungs also showed in the lungs pulmonary nodules for which he's following up with pulmonary. No tissue biopsy has been done, and they are unclear as to the source of these nodules. So he's still getting follow-up currently at the VA. This wraps up my presentation. I just want to thank Dr. Wells, Dr. Thames, Dr. Kumar, and Dr. Sachdeva for their thoughtful input into this particularly complicated case. Thank you guys so much.
Very good, Bo. Thanks for that review and that very interesting case. I want to ask some sort of clarification questions with the case. So do we think what was going on in his radial artery was paradoxical embolus, or what?
Yeah, so we did think about it, and upon review of the echo images, given the size of the PFO, we thought it was unlikely to be from the DVT in this body. So we did think about the connection with an incidental small PFO finding, but we thought, given the size of it, this was probably unlikely.
And then what was going on in the RCA?
So that was the question that we still to this day don't have a good answer for. We suspect he probably had a developing SCAD in that vessel in the previous 1 to 2 days. And then he had a thrombotic event in that vessel, which correlated with his initial symptoms that he presented with. But of course, there's no angiographic data for this.
Yeah.
And to this day, we don't have a good explanation for what happened in this RCA.
And then a chronic dissection of the obtuse marginal.
Yes, sir. Yeah.
This guy, and then the acute dissection of his. His EKG was consistent. There's obviously something going on in his. It seems like there was something going on in his LAD before he walked in the door, right? Based on the EKG, but it's just like, geez, this poor guy. Occam's razor is out the window with this guy. So okay. Right. Clear as mud, but a very interesting case. Any questions, comments from the group?
Stan Sherman. Can you hear me?
Yep.
Okay, bye. I'm just wondering, his clotting, did he have any hematologic evaluation, clotting studies or anything?
We did consult hematology, given his array of findings, and per the consult note, they were not impressed with a hematological origin of his conditions. So they didn't think he had a clotting disorder. And so we did consult them, but overall they were not impressed.
Interesting case. Thank you.
Thank you.
Any other questions or comments from the group? I guess, the other thing I'll bring up is, right, you touched on it a good bit during your presentation, is that you talked about how ideally you want to leave these alone if possible, but clearly that LAD looked pretty bad acutely, and he was having a lot of symptoms. So I certainly, don't want to play armchair quarterback, and it seemed like it turned out okay in terms of revascularizing his LAD. But just sort of any other comments about sort of based on your discussions with those that were involved in the case, was there a lot of discussion or consternation about intervening on that LAD, or was it pretty clear cut to them based on the clinical scenario?
Yeah, I think what drove us to intervene was the fact that once we were touching up the RCA, he had resolution of his chest pain. And then very acutely, he became, in distress. He had this recurrent chest pain. He was able to articulate to us that the pain that brought him in occurred again. And so when we investigated that, the angiographic findings with his clinical symptoms, we decided this was probably active ischemia, and we had to intervene. So I think he had pretty clear cut, resolution of his chest pain when the RCA was revascularized, and then recurrence. And then after we shot the left and saw it, that made us pursue it.
Hey, Robbie.
Yeah.
Bo,
Yes.
that was very good. I hate to think of how many of these we've missed in the past. When you have the type that's just simply mild, diffuse narrowing for a couple of centimeters in the down the mid portion of the marginal or diagonal or something like that. We tell the patient not to worry, and all along it was dissection. So that thought occurred to me every time I hear the subject presented. That was very good. Thank you.
Thank you.
Okay, well, yeah, I agree. I mean, there's probably a whole bunch of type 3s out there that, were just dismissed as, luminal irregularities that might have been, SCAD, which, in terms of the conservative management of these patients probably doesn't make a whole lot of difference. A lot of the management's the same, but like we talked about the other things you need to worry about in terms of imaging, the mesenteric vasculature and, cranial vasculature, and thinking about connective tissue diseases and all those things when you do have confirmed SCAD. So that's what you may potentially miss, when one of these sort of mild cases is just dismissed as run-of-the-mill atherosclerosis. All right. Well, again, thanks everybody for tuning in today. Faculty, don't forget to go in and claim your CME credit, and we'll see everybody next Friday.
The preceding program is copyrighted by Emory University.